Good morning, everybody. I love those opportunities for getting to know people who I didn't know before and having us have come here and talk to us. So it's a pleasure to have Dr. Muhammad Abd-El-Barr from Duke coming to look at the position we have here and give us grand round this morning. Muhammad grew up in Saudi Arabia, then in Toronto, was born in Saudi, went to Canada, Toronto, went to college there, and then from there went to UT Austin, where he did his MS in biomedical engineering. From there, MD, PhD at Baylor, next door, where I guess you didn't meet my cousin when you interviewed there. From there, went as an intern in Gainesville. From there, did his neurosurgical residency at the Brigham, stayed for fellowship, and after that moved to Duke in 2017, where he's now an associate professor, about to become professor, as far as I understand, at his very tender age. So congrats. And you wouldn't believe it, but you look at him, he's got a 20-year-old and then 2 younger than that. So listen, we're excited that you're here. We've got several of the faculty and almost all the residents and several fellows. So please come and tell us. I think you're going to talk about the MIS or whatever. Yeah.
Thank you so much, Dr. Morphos, for the great introduction and for the invitation to come here. It's a real honor to be here. This is our second home, Houston. Our kids are born all in St. Luke's, so very familiar grounds, and it's a great honor to be here. So today I'm going to talk about pushing the limits of minimally invasive spine surgery. I'd like to keep it as interactive as possible. So if you have any questions or concerns, please raise your hand or something. So here are my disclosures. So talk a little bit about the objectives of today. We'll talk about, what is our motivation, and then talk about some things that we've really instituted to make spine surgery safer, more efficient, and better for the patients, and maybe even better for ourselves as practitioners. So if we look at the definition of minimally invasive spine surgery, the incision is not the most important thing. The most important thing is that we have to do the goals of surgery, but we have to be nice and gentle to the overlying tissues. So our objective is to operate on the spine. We shouldn't wreak havoc on the rest of the body that we go through to do that. If you look at Hippocrates, he said, if you have 2 choices for a patient, you should choose the one that's least troublesome. So we're going to start off with a case. 87-year-old gentleman with the American past medical history, lots of back pain, lots of leg pain. He's got a degenerative scoliosis. If you look closely, he's got a grade 1 spondylolisthesis at L4, L5. He's got stenosis at L2-3, L3-4, L4-5. So pretty difficult case. 87. He's been to lots of other surgeons. They told him, listen, you're 87. There's nothing we can do for you. You just need to, live with the pain. And he says, you know what, doc? I love to ride my motorcycle. I play in my church band, right? And I want to do those things. And he has a younger girlfriend, and he wants to enjoy life. He's 87. I don't want to just stay in bed. So I think a very legitimate question is, should this patient even get surgery, right? As one of my former partners used to say, it's only the first case that's elective, and then you're chasing your tail. So, they come to you with these, eyes, and they say, please, can we have surgery? And really, at this point, as spine surgeons, it's really, we leave it up to what we call gestalt. I don't even know what that means, but I think we can do a little bit better than that. So one of the things that, has been the buzzword around here is machine learning. So we actually did a review, and then we're doing some more things, looking at machine learning to diagnose back pain and to look at what we should do. This paper was just accepted into the Spine Journal. So if you look over the years, there's an exponential increase in the interest in machine learning. Most of it is on risk prediction and detection. Not a lot about whether we should actually do surgery. And I think positively, a lot of people are not just looking at imaging, right? We're going to look at more things, kinematics, posture, balance, and so on, before we say this patient should have surgery. If we look at when the patient comes in with back surgery or back pain, it's kind of a wild west, right? There's so many different ways that the patient can do. And unfortunately, where they enter the health system often portends what they're going to do in the future. That really shouldn't be the case. You know, as doctors, as physicians, we really want to push so that there's a systematic way to treat patients, right? And it shouldn't be very subjective. It should be objective. So actually, we put in a grant with the Duke Health System, and this is a big problem with all these big medical systems, right? Is what to do with these patients with low back pain. It's the number one reason for disability, and we really don't have a good way to manage them systematically. So we're actually using machine learning to try to understand what should we do for these patients. Now, we spent a lot of time actually just thinking about what is success. I know Dr. Morcos was talking to Dr. Sandberg here about a patient with microvascular decompression. We can say when that surgery is successful, but what do we say about people with low back pain? How do we define the success? If we look at only patient-reported outcomes, that can be very subjective, and it cannot be the best thing for the patient. So if I had Mrs. Jones came into my office and I gave her a lifetime supply of morphine, her patient-reported outcomes would be pretty good, right? But she has a grade 2 spondy, probably should have treated that instead, right? So we need to look at that. So what we look at is actually healthcare utilization. So if Mrs. Jones is able to return back to work, doesn't have to go back to the ER, is not taking opioids, right? Her healthcare utilization after the surgery would be really, really good. Or if she had PT and she did really well and her healthcare utilization would be better. Another way we can look at is opioid use. So this is a very preliminary results. So I'm a little bit ashamed because right now our models aren't so great right now. We're a little better than chance to figure out whether a person will be opioid free after surgery, but we're working on it. So what we'd like to do is go from this workflow that's there to a more systematic way. So patient comes in, they give their demographics, they give their lab results, they give their imaging and so on, and then we can sift them through and say, you should go to physical therapy, you should go to chiropractic, you should go to surgery. And this is a big problem, I think, in all big health systems. So we have to understand that surgery is traumatic for the patients and for their loved ones, and a little bit for us. So I was recently, last year actually, at the CNS, was invited to give a talk about enhanced recovery after surgery. I think this is a misnomer. It really should be enhanced recovery with surgery, right? It has to be a continuum of care. So we've really broken it up into different phases of care. And at each phase, we're trying to minimize the surgical footprint and the anesthetic footprint on these patients. So in terms of preoperative optimization, we found, there's 8 modifiable factors that you should really optimize before you take these patients to surgery. And we published on this. And right now, actually, in our EPIC, after I see a patient, I say, you know what, I think you might be a good candidate for surgery. It actually goes into the EPIC, and the nurse comes in and asks these questions. And if any of them are positive, it makes a red flag and say, hey, maybe before we sign this person up for surgery, there's an optimization that we should do. I think very important. I think this is something that Dr. Shaffrey instituted when he first came to Duke. And I don't know if you guys have this, but it's a multidisciplinary indications conference. So this is the orthopedic surgeons, this is the spine surgeons, this is the physiatrists, showing cases that we have, some, equipoise, what should we do? And we talk about, hey, how can we manage these patients better? So now we finally went through machine learning, we went through the indications conference, we finally decided that this patient is appropriate for surgery. We really have to think, more than just our surgery. I think an equal footprint on these patients is anesthesia. And sometimes as spine surgeons, we ignore that. And I think that we have to realize, especially for the older patients, anesthesia can be just as important footprint as surgery. How many times we do the perfect surgery, patient's back pain is better, patient's leg pain is better, but they don't remember who they are because they have post-op delirium, or now we got to deal with post-op nausea and vomiting, right? So we've kind of not done ourselves any good. So it's really important to have good collaborations. I'm lucky to have a great group of anesthesiologists at Duke where we collaborate on a lot of these projects. And for us, we've actually made an analgesic kind of workflow. So the patient comes in, they get preemptive analgesia. If they're a candidate for it, they get a regional anesthesia, could be an ESP block, could be a QL block. Then if they're a candidate for awake spine surgery, they'll have spinal anesthesia and the post-op management. So regional anesthesia, I think As neurosurgeons, we probably aren't as good understanding. Our orthopedics colleagues understand this a lot better than us, and we've really worked on regional anesthesia. So now depending on where we're doing our surgery, we give dedicated blocks to what we think those muscles are going to be most effective for. So right now, when we look at spine surgery, our current planning is spinal pelvic parameters. I think that's very valuable, but we all know that the spine is so much more, right? We have looking very in detail about the bone structure, the nervous structure, and so on. Why, as neurosurgeons, we would do this if somebody had a brain tumor. Why do we not do this for our patients that have spine problems? So this is actually imaging that we get from Brain Lab that we use in the spine. And then we can look at very in detail about the nerve structures, the different pathways that we can get into the disc and so on. What we've also done is we've broken down fusion surgery into different steps. And at each step, we've said, can we minimize the trauma to these patients? So if you look at placement of pedicle screws, I was trained by Dr. Mike Groff at the Brigham. He's an open surgeon, right? And I'm very comfortable doing open surgery. But to do open surgery, you have to do a midline incision. You have to do a periosteal dissection, find your anatomical landmarks, right? So for placing pedicle screws, we go from medial to lateral, and then we put screws from lateral to medial. Well, can we, circumvent that by actually just going from lateral to medial? And this is where we use this Wiltse approach between the multifidus and the longissimus muscle. So minimal invasive spine surgery, very good for patients in terms of blood loss, length of stay. But there's something that is I call it when I go into the OR, a silent killer, and that's fluoroscopy. If we're no longer seeing what we're operating on, right, we have to use fluoroscopy to know where we are. And fluoroscopy and ionizing radiation is not safe. So for all the females in the room, if you're a female orthopedic surgeon, you have 5 times the risk of developing cancer as the general population. Wearing lead and everything. I just want that to sink in. So that's something that we really have to think about. So every x-ray I take in the operating room, I have to think very carefully, why am I doing this? Okay, this is a system that was developed at Duke by one of my former partners, and I'm one of the co-founders of this. And this is what we call computer assistant instrument navigation. So what we do is we put the fiducials on the C-arm, it's not on the patient, and then we use an infrared camera, but now this is fluoroscopy based. So now we can actually navigate using fluoro. So there's not a long time for doing a C-arm spin, an O-arm spin, and so on. For the residents, one O-arm spin, do you know how many chest x-rays that is? Yeah, it's actually closer to 500. So every time you subject a patient to one O-arm spin, that's 500 chest x-rays, right? So this is based on fluoroscopy. And you can see here, you can actually see where you are, where you're gonna be, both in the lateral and in the AP, right? And I can have 2 instruments going at the same time. So that makes my surgery much more efficient. So we published this. This is not a randomized control study, but what we did is we actually used the patient as their own control. So I used normal fluoroscopy on one side and the instrument navigation on the other side. And we showed that we could decrease the amount of radiation by 70%, and we could decrease the amount of time by 60%. Okay, Dr. Abd-El-Barr, we'll get this also. One thing that came also is that when we're looking at the data, sometimes when you're trying to put in a perk screw, it's so hard to find that starting spot. So every time you move, you got to take an x-ray, 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 right? Sounds like a bar, like shot, shot, shot. No, we don't have that, right? You see how low the variation is when we use the instrument navigation. Well, Dr. Abd-El-Barr, you put in your screws very fast, but they're all in the canal. Well, we showed that wasn't the truth as well. So we got CT scans afterwards, and we actually compared it to my robotic screws, and they were just as accurate, about 97%. So that's placement of pedicle screws. So now, if I'm doing a 1 or 2 or 3 level fusion, it's a Wiltse incision. The resident and the fellow are on one side each, and they're putting in screws, and they go in very, very quickly. How about interbody fusion? So if we look at posterior fusions, if we look at the TLIF, we're really trying to do this thing called patient-specific TLIF. So, the way we were taught, most of us as neurosurgeons, is we go from the inside out. So we do a hemilaminectomy, we find the theca, we push it to the side, and we put a cage. Now, if you're trying to do that through a tube, that can be quite scary, right? You got this little small nerve, and you're trying to put this big cage in. Another option is the kind of outside in. This is kind of like the pedicle-based systems. And we'll also talk about the transfacet TLIF. For some of us as neurosurgeons, that might be a little bit difficult. And then there's a new way of this percutaneous way, which is through Camben's triangle. So Dr. Camben was an orthopedic surgeon that really looked at this. And I think for the residents, Camben's triangle came on your written board exam. Yeah. So you got to know it. So I think I agree with Dr. Mike Wang when he says it's a three-dimensional structure. So we really should think of it as Camben's prism. So we did a systematic review looking at, how Camben's triangle changes as you move in the spine. We found that as you move caudal, the area will increase. And then just as our endoscopists will tell us, if you do a foraminoplasty, you take off the SAP, you can actually double that area. Now, this is anatomical. As surgeons, we deal with pathology, right? So if you have a spondylolisthesis, if you have a disc herniation, we actually found that that area will actually decrease. So you have to be a little bit more careful and a little bit more scared. So for us, how this, as we said, we do the Wilson incisions there. And then we have an incision that's usually about 12 centimeters off midline to enter into Camben's triangle. As you guys know, the safest way to get into Camben's triangle is more distal. And on the AP, it's right in the mid-pedicle point. If you're too medial, you hit the traversing nerve root. If you're too lateral, you hit the DRG. And hitting the DRG is not a good thing for any of the patients. So I come to these talks and I'm dressed all nicely and everything looks great. And these sounds looks rosy, but not everything has started rosy. So this is us at the beginning of our journey. So you can see lots of blood everywhere. There are two C-arms, right? One in the AP and one in the lateral. It used to take us half an hour just to set it up. It was miserable, right? If you're doing 2 levels, you have to spend half an hour for each level to try to set it up. The residents didn't like it, the radiology technicians didn't like it. It was quite miserable. And there's a lot of setup time involved in this. So there's no way I'm doing an awake fusion if I'm taking half an hour just to set up the C-arms, right? And as we started getting good with the computer-assisted navigation, we said, well, why don't it tells us where we are in the AP and the lateral. Why don't we use this to enter into Camben's triangle? And that's what we did actually in the same paper. And we found that surprisingly, I could enter into Camben's triangle faster than I could with the 2 C-arms and all the setup time. So now it's becoming much, much faster. Now we can start engaging the anesthesiologist. Hey, can we do the surgery under spinal anesthesia rather than general anesthesia? So here's an example. Grade 2 spondy, bone on bone. It's pretty bad, right? This person is a resident of Durham, so he's been shot in the abdomen, so we couldn't really do an ALIF or lateral. Lots of things going on in the abdomen. So very difficult case. So I said to the resident, and I had a PGY2, I said, let's put in the screws first and maybe we'll do some distraction and we'll see. And I'm sure the resident was like, oh my God, it's gonna be a miserable case. But we put in the screws and I said, let's try to do it just with the instrument navigation first. So here it is. So on the left there, that's one X-ray. So now I can see my instrument. On the lateral, take an X-ray. And now I can see where I am both in the lateral and in the AP. And so not every time I'm moving, I'm taking an X-ray, right? I'm moving, and I can take an X-ray if I just want to make sure. Now I'm entering in. We have this bullet notes inserted there. So taking 4 X-rays so far. Now I'm in. This case took 47 minutes skin to skin. So in terms of our current TLIF algorithm, I don't want people to think that I only do TLIFs or only TLIF is the way to do it. There's the other surgeries that are reasonable. So in my algorithm, if I have a multi-level degeneration or have a deformity, I will do open or hybrid circumferential fusions. And we'll talk a little bit about that if we have a chance at the end of the day. If not, if it's just a 1 or 2 level, then what we're doing is using that BrainLab computer program figuring out, is Camden's triangle, quote unquote, big enough, right? If it's big enough, right, then we're going to do something else. If it's not big enough, then we're going to have to use more of the transfacet pathway. If it is big enough, then we can use, we have to think about whether we want to do a direct decompression. If we don't, we can do the percutaneous way. If we do, we have different options. How about robotics? I think you guys have a robot here. So we've been very interested in using the robot. We've actually used it for not just placing the pedicle screws, but actually entering into Camden's triangle. So we kind of hijacked the software and actually put a screw into Camden's triangle. See that on the right there. So here it is. You can see we're entering into Camden's triangle here. This is the first awake case I did at Duke. This was a gentleman that I inherited from the VA. He had previous hip surgery and said, listen, doc, I don't want to have general anesthesia. And we were able to do he had a grade 2 spondy. We were able to do the surgery in less than 2 hours. This is the blood loss after the surgery. This was done robotically. And we published on this using the robot to enter into Camden's triangle. Now, how about the nerves? We haven't been looking at the nerves with most of the robotic software that's out there. So as I said, we're using this BrainLab software to look at the nerves. We can then measure Camden's triangle on each side. And so if I don't have to do a direct decompression, I can use the larger Camden's triangle to enter in. We can get ourselves out of trouble before we find ourselves in trouble. So here on the right there, you can see that on this case, I could not find before we did surgery that we have a conjoined nerve. I'm not entering on that level. Not surprisingly, we found that if you take the nerve into consideration, the area for Camden's triangle will decrease. And so now I have some great medical students that are manually segmenting up these nerves, but now we've kind of built a database. And so hopefully in the next year, we'll actually have this all automated so that as soon as you walk in, the person has an MRI, we'll actually be able to have all of this automated for you. And then we've been looking at a screen. I think nowadays and so on, we're working on ways so that we can actually look through the patient. So here's a case that I'd like to present. This is a 70-year-old lady who had a grade 2 spondy. And so we had scheduled her for a 2-level TLIF, and then COVID hit. So they canceled her case and they said, no elective surgery. And then COVID was going down. So she came back to me a year later, said, my back and legs still hurt. I need to have the surgery. So I scheduled her for a 2-level TLIF. And then the day before her surgery, Omicron hit. So the head of the OR called me. She said, Dr. Abd-El-Barr, you got a 70-year-old lady. She's going to need a 2-level fusion. We have no beds in the hospital. You're going to have to cancel her case. I said, this lady's been waiting for 2 years for this surgery. I had talked to her about the possibility of doing this case awake, but I hadn't, kind of finalized it. So I said, listen, let me talk to the patient and let me see if she'd be willing to do this awake. She said, okay, no problem. But if this patient even spends 23 hours in the hospital, there's no more elective surgery for you. It's tough. 2-level. I have to have her out of the hospital by PACU. Kind of nervous. So this is what we did. We did an erector spinae block, and the patient wanted this. She's like, I can't wait. We did the spinal anesthesia. They bring in their earphones. They're listening to it. We put in the screws using this instrument tracking system. Since we're putting in both screws together, it's much faster. Then, I don't want to sacrifice safety. So I'll get a CT scan after the screws are in to make sure all the screws are good. I'll put a reference array and the PSIS. I'll merge that CT with that preoperative MRI. And then we're able to percutaneously enter into the disc. So here is, and this is basically using BrainLab software that we're all used to. You can see here, we're entering the disc. We're avoiding exiting the traversing nerve root. And we were able to do the surgery. This is completely percutaneous. We lost 50 cc's of blood. The PT people came to the PACU. They walked the patient. She had no problems, and she went home from PACU. If you told me, as a resident or fellow, that you're going to do a 2-level TLIF and have the patient go home from PACU, I would have said that's impossible. But it's a reality. And we didn't, kyphose her. We did pretty good with her. spinal pelvic parameters. So we got really good at this, entrance into Camden's triangle. I was feeling good. But then I had a couple of patients that had kind of DRG kind of symptoms. I said, let's study this a little bit more carefully. So what we found is that in some people, if you look very carefully, their Camden's triangle is too small, right? This one here is 6 millimeters. There's no cage that's 6 millimeters. If I go in there, I might hurt this patient. So this then got us more interested in this transfacet pathway. So this is a paper that just got published in Operative Neurosurgery, looking at the transfacet corridor versus the Camden's corridor. We found that in general, the transfacet corridor is larger. So here's an example. This guy's a 32-year-old guy, got a grade 2 spondy, wasn't able to play with his kids and so on. He did not want a ALIF, and he didn't want a lateral. He wasn't actually a good candidate for those either. So this is the pre-op segmentation that we do. Again, we place the screws with the instrument tracking. We merge the CT to the MRI. And then now, since it's not percutaneous, it's using a tube under the microscope, what we can do is actually use the microscope and use the heads-up display that we're used to in tumor surgery. So here we are drilling in the facet joint, and it can show us that we're doing that as well. And what we're working on is then actually seeing the nerves through the bone, so I can let the residents do more because I know that they're safe. And again, we're able to do these surgeries and have patients do very well. If you've been paying attention, you say, okay, Dr. Abd-El-Barr, you're doing great stuff, but you're not decompressing these patients, right? So we've looked at decompression as well. We did show that if you look at the percutaneous fusions where there's no decompression compared to the MIS surgeries where you could do decompression, we did show that those patients that had the percutaneous one were using about 40% less opioids, right? So minimizing that surgical footprint really makes a difference for these patients. So that's what got us into actually endoscopy, is that could we do the percutaneous TLIF and then use an endoscope to do the decompression? And so we're working on this now, is using the endoscope for our decompressions. Now, you've heard me a little bit talk about, awake spine surgery. I gave you a couple glances. Why would we even think about doing awake spine surgery? It's not because anesthesiologists are lazy. It's because, as we all know, anesthesia is not benign, right? There's a lot of consequences that can happen with anesthesia. So this is a paper that we looked at a systematic review. We found that people that underwent spinal anesthesia had shorter operative times. We say, why? The scrub techs know that when I have a awake fusion, I'm on top of my game. Everything has to be perfect because we have 3 hours before the spinal wears off, right? So there's no little dallying. It's got to be perfect, right? Multi incision, screws in, interbody fusion. It's got to go like clockwork, because if you're stuck and the patient, starts having pain, the spinal wears off, you can redose it, but it's painful. And I found that anecdotally that even if the spinal hasn't worn off, patients can't tolerate being prone for more than 3 hours. They just get, sick of it. You have decreased blood loss. You have less hypotension. You have less nausea and vomiting, less time in the PACU, less length of stays. Now, most of these studies were decompression, so we decided to look at awake fusions. So this is a paper that we published. This is a matched cohort. So we matched the patients in terms of their age and their BMI, whether they were awake or asleep. And we found a couple of things. For 1 or 2 level TLIFs, 90% of these patients that were done under spinal could go home within 23 hours, right? So now you can think about doing these cases at an ASC or outpatient surgical center. This data actually kind of surprised me. So 50% of 1 or 2 level TLIF patients use 0 opioids in the hospital. Why? Partially because when you're under general anesthesia, you're asleep, and then you wake up and you're like, oh my gosh, I'm in so much pain. And so we're trying to play catch up. When you're under spinal, the spinal wears off slowly, right? And you're awake. You can tell the nurse, hey, I'm in pain. They can give you things to help you with that. So this is a great boon to these patients. Also, the patients ambulate faster. So this is a apples to apples. It wasn't a randomized control, but it's a match control study, right? But I make the argument that spinal anesthesia allows you to operate on a bunch of oranges as well, that you simply weren't able to operate on before. So here's a case series that we published. Some of these patients have ASAs of 3s and 4s. This one here is a memorable one, 91-year-old. I'll show you her picture right now. So this is a 91-year-old from Tennessee. This is not my work. Who had a L5 compression fracture, and the neurosurgeon in Tennessee put her to sleep and did this hypoplasty. And it took her 5 days to extubate. She was 91. She got pulmonary hypertension, got CHF, and her back pain was better, but now she has a ridic. And the surgeon said, ma'am, it took me 5 days to extubate you from this. I really can't do anything for you. I'm stuck, right? So she came to our house, and what we did was we did a spinal anesthesia, and we did an over-the-top decompression. And we got this 91-year-old, now she's 92, back home the next day, right? So this allows, what I'm trying to show is that with the spinal anesthesia, it allows you really to operate on patients that simply were horrible surgical candidates before. So back to our 87-year-old with the 3-level of disease. Remember him from the beginning? What are we going to do with him? So for all the trainees, I want to really stress that, you feel that you guys are younger and so on. I think that you guys are so smart and really can help us. So I require that the residents call me the night before so we can talk about cases. So we had this case, I had a fellow, and he called me the night before, and I told him, listen, and this is actually Dr. Andrew Chen, who's now attending at Columbia. So I don't know what to do. This guy got 3 levels of disease, I got 3 hours of surgery. Maybe we should just do the fusion first and bring him back to the decompression. And Andrew's great idea was like, no, let's not work in series. Let's work in parallel. You do the fusion at 4-5 while I do the decompression at the top two levels. So that's what we did. We brought in 2 microscopes. So I think this can only be done in a big medical center like here or at Duke. So we brought in two microscopes. Here's us doing the fusion. So this is Andrew on the left there doing the decompression, and me on the right side doing the fusion at the same time. I think this is one of the coolest videos. So fusion on the left, decompression on the right, simultaneously. We got good results. We reduced the spondylolisthesis. It's basically percutaneous surgery. So we got the case done less than 3 hours. We lost 50 cc's of blood. I got this 87-year-old with 3 levels of disease out of the hospital within 24 hours. We published on this, we call it the in parallel technique, and we've actually used it for multiple cases now. And the best part about it is that 3 months later, he sends me this picture. He's riding his motorcycle. I hope he's wearing a helmet. I don't remember. And so, that 87-year-old who was stuck, we've really given him a new lease on life. So we talked a little bit about awake spine surgery to avoid the problems of general anesthesia. Now, as neurosurgeons, we're used to doing awake cranies to look at eloquent cortex, right? So as a spine surgeon, there's nothing more eloquent than nerve function. So this case really made me a believer. So this is a 73-year-old who is a NASA engineer. He had a 2-level LAMI done somewhere else, but he still had bilateral S1 redics. And the other surgeon did a good job on their LAMI, right? And so people were like, well, you got to have an A-lift or a T-lift. He's like, I don't have back pain. Why are you going to do a fusion on me, right? And so what we did for him is we did an awake, but not under spinal, actually just under local. And so what we did is, here we are using the endoscope. So he's awake. We're going to start doing our foraminoplasty here. You can see the yellow ligament there. And as I'm taking pieces of the yellow ligament off, he tells me my leg pain is better. I didn't believe him, but I said, okay. And then I did the other side, same thing. And now he doesn't have a spinal to wait to wear off. So it's just local anesthesia. So he goes home from PACU. So I think this really shows that, you can use this to your advantage, even for looking at eloquent cortex. So that's kind of the ultra minimally invasive spine surgery. I'm going to switch gears, if that's okay, and talk a little bit about how we can use kind of hybrid techniques to help other patients that don't have simple pathology. So this is an 82-year-old who I did a 2-level TLIF on before, and now has adjacent segment disease, right, at L2-3 and L3-4. Now, as a fellow, this was like the worst case for me, right? Because the attending would leave me alone. I have to do a midline incision, and I'd spend hours just trying to expose. I really don't want to put that bovie through the dura. I'm like, it's going to be miserable, right? But I think that we can actually do better for these patients. So open 2-level TLIF with extension of fusion, that's what I did during fellowship. But how about lateral? Can we do a staged lateral and do an extension of fusion? If we look at the biomechanics, actually the lateral is better for this patient. And so this got us into the prone lateral. So we know that if we talked to Dr. Morcos, so if you put the patient prone, you can actually do the 2 parts of the surgery all in one. You can go lateral and have the advantage of the lateral, not go through, all the scar tissue. But then you're also prone. You get 5 degrees of lordosis just from positioning the patient. If we're, fighting for every degree, why wouldn't we get something that's free for us, right? And so this is how it looks. You have the patient prone. I push it a little bit lower so I can really accentuate that lordosis. I have my incision for the lateral part, and I have my Wiltse for the posterior part. So now this patient can undergo basically a percutaneous surgery, right? Where I can do the 2 levels of fusion from the side, and then I can just go on Wiltse, take out the old screws, put in new screws, extend his fusion, and now we can do this with 200 cc's of blood loss, right? And we can have these patients going home the same day or the next day. And we're using this instrument tracking to actually help us. So when you're prone, if you're trying to get into the perfect spot, but the C-arm is in the way, it gets really difficult, right? But with this instrument tracker, I can actually move the C-arm out of the way. So now I can actually let the residents do a lot more because I can see where they are and what they're doing. You can see it as they're tracking there. And the C-arm's out of the way, so it's not in my way. And again, we're decreasing the radiation. So like that would be a perfect entrance into the disc from the lateral position. We can actually look at the retractor. We can make sure that the retractor is orthogonal too, right? So we don't want to have that retractor going too dorsal or too ventral. We can actually know where that retractor is. And as I open it, we can actually see it. So we can have basically perfect placement, right? And this is, a lot of people say, well, why don't you just do an O-arm spin? We don't need to do 500 chest x-rays. We're doing 2 or 3 x-rays. And so now we can do this surgery and do pretty good. So we published on this using adjacent segment disease using the prone lateral. And we found that if you put a 10-degree cage, you can get 10 degrees of lordosis afterwards. Usually the mantra is in the lateral surgery, unless you do osteotomies, you're going to get half of the cage. But what we found is probably you're getting half of the cage, and then you're getting the 5 degrees of the lordosis from positioning. How about more complex deformities? So this is work that was done by the ISSG looking at different ways, different categories. So this is a patient, 65-year-old. This is not considered a simple surgery. So what we did is we did a 2-level ALIF. We did a 3-level prone lateral. We stood her up, still not doing so well. So we said, hey, we know how to do open surgery. Let's do open surgery and correct her. And so now we get, these types of results. So not just because, again, just because you're really good at one thing doesn't mean that you can't be good at everything. You really need to do what's best for the patients. So we published on this using deformity correction for the prone lateral. And we showed that we're getting excellent radiographic results as well. How about class 4 deformities? This is a patient comes in, has had 3 or 4 different surgeries. You can see how flat the back is. The PI-LO mismatch is 40 degrees. Very difficult case, right? So we put the patient prone. We do an open exposure, and then my colleague, Dr. Bomek, will actually do a PCO at that level, at that 2-3 level, while I'm lateral, and then use a laminar spreader, open up that disc space, and then I can put in a cage at the 2-3 in the lateral position. At 2-3, it's difficult to do a good T-lift and so on. This way, we can do that much better. So we also did a L4 PSO on this person. So we're getting wonderful results. So we're using both open and minimally invasive techniques to really help our patients. So in terms of other, post-operative care, we've started to look at this. As I said, we're getting the PT people to come to PACU to work with the patients, right? There's no reason for these patients, the thing that, if I have 3 or 4 cases, I do the first case, patient goes to the PACU, then they go to the floor, and come at the end of the day, nothing's happened. They've been done for like 12 hours. 12 hours that we're wasting for these patients. I'm working with Dr. Ladd on this mobile app to actually take care of the patients when they go home. So it tells them, okay, Mrs. Smith, you had your 2-level TLIF. It's normal to have some pain and so on. And we actually showed that it could decrease the ER visits by about 35%. So I'll start wrapping it up so we can have some questions. I think that, if we look at the future of spine surgery, I think individualized care is so important. We would want that for our brain tumor patients. We'd want it for our pediatric patients. Why wouldn't we want it for a spine patient? So looking at preoperative optimization, these diagnostic tools that get us to best treat these patients. I think these intraoperative adjuncts are really important. It's allowing us to do surgery safer, faster, and better for the patients. And then post-operative care, I think these digital care pathways are really important. As I tell the residents, the future is now. Just to conclude, I think minimally invasive spine surgery is exciting for the patients and exciting for us, right? Half the surgeries I do now, I never was trained to do as a fellow, right? We're always learning, right? So I think that's really exciting. I think, I really am a big believer in patient-specific and pathology-specific treatments for patients. And I think collaboration with nursing, orthopedics, physical therapy is really going to be the key to making sure that we take care of these patients in a good way. And I wouldn't be able to give these talks if I didn't thank the mentors that I had. So, I went to medical school just across the street. Dr. Sam Wu was my PhD advisor. I worked on neurophysiology of vision. There's Dr. Sawaya, Dr. Morcos. And so many people have been really instrumental to getting to me to where I am. And then the best part is that I've been able to mentor other people that are now attendings and residents and fellows all over the country. With that, I conclude. Thank you so much.
I'm sure people will have questions, particularly my spine colleagues. And by the way, Eric Kleinberg is here. That's head of spine.
Late cases, it's very intriguing, and I can see the argument very well. 90-year-old, otherwise, in general, I think general anesthesia is pretty safe. I think you might be allowed to listen to a healthy 40-year-old who doesn't want to just put me to sleep. I don't want to be in that position. Yeah. What are patients' preferences?
That's a great question. We're looking at it. And I would agree. I think that we see the biggest benefit in the older patients. Now, luckily, most of the patients I treat are older. But, it's true. Like if I have a 50-year-old, there's a little bit of equipoise. So actually, we have a study that was funded by the AO looking at that. So we're going to try to do a randomized controlled trial on that. What we found anecdotally is that there are some patients that are very susceptible to general anesthesia. And we don't know that biomarker yet, but we're going to look at that.
I don't know much about spine, as you know, but I was listening to some debates recently for endoscopy, uniportal versus biportal. Is that something to think about? Or is that important?
Yeah. So, we have a pretty robust endoscopy program that we've built at Duke. It really, again, it's very pathology specific and patient specific. So for transforaminal discs, right, I think the uniportal is really good. For biportal, I do biportal, but, the 2 incisions are not that much smaller than the regular incision. The advantage of the biportal is that you can go a little bit faster and you can use the instruments that you're most used to. Now, you may say foraminal discs are pretty rare, right? But what we've actually found is that some people with scoliosis they have a one-sided radiculopathy, right? And so we've tended to try to correct their scoliosis, but some people will actually do better with just an endoscopic decompression. So we actually have a paper coming out looking at endoscopic decompressions for scoliosis. So I think that the applications for endoscopy are going to be increasing, and not, because the, foraminal discs and so on are pretty rare. But for these cases with one-sided radiculopathy, I think these patients can do very well.
How many spine neurosurgeons have you in neurosurgery? Are you specializing amongst yourselves?
Yeah, we have a huge spine division. So including the orthopedics, I think we have 18 spine surgeons. And we've started to kind of, specialize. They just named me actually chief of endoscopic spine surgery there. So, I'm going to be focusing endoscopic. If I have a large deformity, I like to collaborate with my other colleagues that like to do deformities and so on. I think that's, the kind of the future of healthcare in general.
Yes, there's still some areas out there. If you were going to, transition where MIS, how would you come in from the literature? It didn't exist for open stuff. What kind of complications?
Yeah, I think that's a really, really important question. And I think there's some parallels with open vascular and endovascular. I was trained as an open surgeon. So if the navigation is off or the robot is off, right? I was doing a like T10 to pelvis and the fellow hit the array. And the immediate response, like, oh, we have to respin. I'm like, no, we don't. I was trained to do open surgery. The question is for our residents and our fellows who are doing more and more minimally invasive things, will they be comfortable, if the robot's not working or navigation's not working? And I think that's a challenge. One of the things that I try to instill in the trainees is that we shouldn't use these adjuncts as our only way to do surgery, right? We should know our anatomy, right? So what I do is actually I do the Wilson incision. There's a reason I do the Wilson incision is I want them to actually feel with their finger, that transition point between the facet joint and the TP, put their finger there, then put their instrument there. Don't look at the screen, right? And say, this is where I would put the screen, right? And then look up at the screen. And if they're totally off, then I know I have to do more work with them in the lab. If they're not off and it's just using it to make simple adjustments, I think that's where, technology can help. In terms of new complications, now that we're doing surgery from the front, from the side, we're looking at things that we've never seen before. I had, unfortunately, one case where we went through the ureter, so we had a uroma, for OLIF, right? Those are things that we never thought of before a spine surgeon, right? Everything was posterior. So there are things that are coming out that we have to be more and more careful. Please.
Okay, well, thanks. Great talk. So can you tell us a little bit about the collaborative environment you have with the surgery kind of work in? How does that work? How does that actually work? And how does that impact the training for the neurosurgeon residents? Is that good? Is that bad?
Yeah, great question. So, we have a combined fellowship. So the fellowship, we take orthopedics, we take people through SF, I shouldn't say orthopedics, we take people through SF match, which could be neurosurgeons. And then we take people internal, could be super chiefs or people come after residency. And now those fellows are totally entwined. So they rotate with both orthopedic and neurosurgery. All our conferences are combined, so our indications conference is combined. We have a didactic program, which I'm in charge of. So every week on Tuesday, we have first one is deformity conference, then MIS conference, then basic science and journal club. And so all the spine surgeons, whether they be orthopedics or neurosurgery, and all the fellows and residents are all together. And so we really have tried to make everything together. We have our kind of painful for us because we have neurosurgery M&M and then we have spine M&M. So you have to present your cases twice, but that's okay. And I really think it helps the trainees a lot because they get to see, this is how the orthopedics people do it. This is how the neurosurgeons do it. And even amongst, they're not all neurosurgeons are the same, not all orthopedics are the same. And so that kind of environment, I think, is a great one. I think that they don't probably, it's kind of a blessing of having too many good things. We've got, Chris Brown, who's probably the best lateral surgeon in the country, right? And they can only spend like 2 months with him, right? So it really doesn't give them enough time to really get into the nitty gritty. We have Dr. Shaffrey, the best deformity surgeon in the world. If you spend only 2 months with him, you're not going to get the nuances and so on that we probably want. So we're actually thinking about maybe splitting it up and having different ways. If you want to be specialized in MIS, or if you want to be, deformity and so on. So I think right now we have a blessing of having too many great options for these trainees.
Any other questions?
Please. Yeah, we currently have the Globus. We just got the Medtronic, so I haven't used the Medtronic yet. I think the robot has some applications, and just like every technology, there's today's iteration and tomorrow's iteration, right? Today's iteration is kind of slow. I call it the slow bot. And then I call myself the Mobot, and I always say that the Mobot is better than the slow bot so far. But that might not always be the case, right? And so there are certain applications. I don't have time to go through this, but with complex pelvic fixation, especially we don't see as much trauma as you guys do, but with a lot of traumas, my orthopedic colleagues will do these transiliac, transsacral screws. We'll have like X fixes and so on, and then they call me the next day and say, "Oh, this guy's unstable. Can you fixate them from L4 to the pelvis?" Right? And previously, that was a slog, and it's really difficult to have all these screws going in different places to really aim and so on. The robot actually makes it awesome. I can do these surgeries actually percutaneously, and I can line up all my tulip heads underneath the skin to really pass it broad very nicely. We have a whole case series about that. And so I do think the robot has really good applications. It just needs to get a little bit better, and it's getting